It's too hard. Yeah. Okay, I should unpack.
That's all.
Okay,
Yeah.
thank you.
You want me to turn the mic on?
Perfect. Okay. Welcome everybody, and thank you for coming out today. I'm going to do my step 2 protocol defense for my PhD at IHPME. So I want you to think back to the last time you had an episode of low back pain or neck pain, a migraine or a headache. I want you to think about how that affected you. Were you able to get up and go to the gym or go for a run? Were you able to sit in your chair at work comfortably, concentrate like you normally would? Were you willing to socialize with your family and friends like you normally do? Overall, how did it impact your well-being? Now think of this from the perspective of a child with cerebral palsy. How would persistent or recurrent pain impact their ability to concentrate at school, their activities of daily living? How would it impact wanting to do physical activities? Would it change how they feel, their moods, and how they're getting along with their friends and family? So in essence, how is it affecting their overall well-being? We know that children with cerebral palsy have a point prevalence of pain ranging anywhere from 34 to 70%, and 1 in 10 report experiencing chronic pain. Of these, 25% report having moderate to severe pain that impacts their activities of daily living. Cerebral palsy is the most commonly diagnosed physical disability among children. There are approximately 17 million individuals with cerebral palsy worldwide, and the diagnosis is associated with a range of other physical and cognitive impairments. So this includes intellectual impairments, visual, auditory, and speech diagnoses. There are additional comorbidities such as epilepsy, gastrointestinal disorders, and mental health disorders. Pain and well-being has been studied somewhat, but there is actually quite a lack of literature in the area of both pain and well-being. Pain is actually under-assessed and underreported in this area. And there's certainly a lack of information about the course of pain in these individuals. So the rationale for my work is to advance the knowledge about the impact of pain on well-being in children and youth with cerebral palsy, hopefully to help guide treatment strategies for pain management, and to aid families and clinicians in reducing the negative impact of chronic pain on well-being in this population. My research question is, are short-term pain trajectories associated with short-term changes in physical and psychological well-being in a cohort of Ontario children and youth aged 8 to 18 years old with cerebral palsy who can self-report on questionnaires and who attend a children's rehabilitation center? So with my 2 primary objectives, I aim to identify 1-month pain trajectories in this population, determine if pain trajectories are independently associated with short-term changes in self-report physical and psychological well-being. And then my secondary objectives, which are more exploratory, are to determine if the association between trajectories and well-being varies by sex, determine whether sex predicts trajectory membership, describe common healthcare utilization and services for CP received during the preceding month, because we know typically these services are quite high, and describe changes in self-reported pain location over the course of 1 month. So in terms of my methodology, I'll be conducting a multi-site cohort study. I'll be drawing from a population of Ontario children with cerebral palsy, aged 8 to 18 years old, who attend 1 of 2 children's treatment centers. This includes Holland Review Kids Rehabilitation Hospital here in Toronto, and also Grandview Children's Centre in Durham. So the catchment areas will be Toronto, and then the entire Durham region. My cohort will be formed of 150 participants, and they must attend one or either of these CTCs. So the way the study will work is I'll do an initial screening with potential participants. Those who are eligible, I'll consent, and then I'll do a standardized questionnaire with them at baseline. Participants will be followed up weekly for 5 weeks. and then we'll complete our analysis after that period. We've already held a stakeholder engagement meeting with the Youth Advisory Committee at the Holland-Bloorview Kids Rehabilitation Hospital. It was really informative and actually quite essential in terms of providing information and how we're going to structure both our pilot study and inform our cohort study. So this is a group of teens with a variety of diagnoses, several of them do have cerebral palsy, who provided feedback on the type of measures we're using, the frequency in which we were going to ask questions, the burden of responding to numerous questions at one time point, and really even just logistics of getting to treatment centers to do research and kind of even feedback around what kind of remuneration they would like. We'll also be conducting a pilot study, so we're just waiting for final ethics approval on that. That will comprise 10 participants, 5 from each site, and this will really provide information around successes and barriers to recruiting, to data completion, and any kind of attrition, and that will feed into information in terms of conducting our cohort study. So I'll be using a variety of different recruitment techniques. The first is the Connect2 research database from Holland-Bloorview. This is a new platform that was launched this past July, and essentially it's a database that has a list of all current clients on caseload since 2011 on. And the beauty of this database is that individuals actually have to opt out of the database. So it's a very fulsome list of clients at Holland-Bloorview, and individuals opt out by letting their clinicians know they don't want to partake in research, or if I were to call and ask a participant whether they want to partake in my research project, they would let me know at that point they're not interested and they would be removed from the list. We'll also have clinicians helping us recruit patients, so this will be through specialty clinics with nurses and administrative staff, including orthopedics clinics, Botox clinics, and developmental medicine clinics. The physiotherapists at both sites will help with recruitment by handing out flyers to all potential participant or potential clients on their caseload. We'll have study posters throughout the CTCs as well as electronic signage. So this is an example of the study flyer that will be posted through the CTCs and electronically. This is actually for our pilot study. So the wording will be a little bit different, but the format is the same as the standard template provided by Holland-Bloorview. We'll have posts on Facebook, so both public Facebook pages at Holland-Bloorview and Grandview. And then Grandview also has a private parents Facebook page, which the administrator vets research projects, and then these are put forth for parents to see the kind of research that their children or they can participate in. And then finally, we'll use the CTC newsletters, which are emailed and posted on the CTC website to advertise the study. We will be seeking REB approval from both Holland-Bloorview and the University of Toronto for the study. So I've alluded to some of the inclusion criteria already, but I'll go through them in a little bit more detail here. So individuals must have a diagnosis of cerebral palsy of any form. They need to be between 8 to 18 years old. They can have any GMFTS level, so this is basically their level of motor functioning, and I provided some pictorial representations along the bottom, and it ranges from level 1 to 5, with 1 being the least affected and 5 with the most physical disability. And then number 5 is participants need to have a willingness to discuss their pain and how it affects them, or their discomfort, or their lack thereof pain. There are 2 exclusion criteria. So because this is self-reported data, we require that individuals must communicate their responses either independently or using assistive devices. And they also need to be able to complete the electronic questionnaires, again, independently or with assistive devices. Now, to clarify, that doesn't mean someone else can't enter the response. So if I'm with the patient at baseline and they use an assistive device to tell me a response, I can enter that into the electronic database. So in terms of exposures and outcomes, for our primary objective, for the first one, the exposure is pain intensity, and this is measured during the past week with the FACES pain scale revised version. The outcome is pain trajectories, and these are based on the weekly self-reported pain intensity over 4 weeks. So remember, we're collecting this data once a week for 4 weeks. Our hypothesis is that we'll have 5 trajectories. These will be those individuals with increasing pain, decreasing pain, fluctuating, stable, or no pain over the 4 weeks. For our second primary objective, the exposure, as just discussed, is pain trajectories. The outcome is self-reported physical and psychological well-being at 5 weeks using the Kidscreen scale, and specifically the Kidscreen 27 scale. And our hypothesis is that compared to individuals who have no pain or improving pain trajectories, those with self-reported worsening, constant, or fluctuating pain trajectories will report lower well-being at 5 weeks. So we have identified several potential confounders, and we're going to use 2 methods to gather information about these. So the first will occur at the baseline interview, and these will be self-reported by the participants using a care checklist. So we're asking participants to report in the previous month whether they've had an operation, Botox injection, they had serial casting, do they use a standing frame, and then some alternative therapies such as hippotherapy, yoga, and so forth. We're also asking about their sleep characteristics using the PROMIS sleep questionnaires, one on sleep disruption and one on sleep-related impairments, and then their ethnicity. We've chosen to collect some data using the electronic health record, and this includes age, sex, socioeconomic status, using a postal code, CP diagnosis, GMFCS level, and then a variety of other diagnoses, including epilepsy, GI disorders, mental health disorders, as well as any pain medication that's been prescribed in the preceding month. So for baseline data collection, we'll use a standardized questionnaire, and this will be completed in person with me. This will be collecting information on specific pain measures. So this includes pain intensity using the Phases Pain Scale revised version, numeric rating scale, which is the 0 to 10 rating scale, and a body pain diagram to identify location of pain. We'll collect information on well-being using the Kidscreen 27, and then, as just mentioned, the potential confounders. Follow-up will occur weekly for 5 weeks, and this will be done via email, link, in person, or by phone by choice of the participant. Most of it will likely be done via email, link, and linking into our REDCap database. And this will be done with a research associate who's blinded to the baseline values. The pain measures will be done or completed on day 7, 14, 21, and 28. And then on day 35, which is our final follow-up, we'll collect information on well-being, the Kidscreen 27, the sleep-related impairment, and then again, information regarding care they've received in the preceding month. So for our analysis, we'll look at the distribution of all our variables to ensure that they meet the assumptions for the statistical test I'll be using. We'll use Lane class growth mixed modeling to identify the trajectories, and this will be modeled based on the weekly self-reported pain intensity over 4 weeks. And we'll look at model fit based on the Bayesian information criteria, and then also non-significant bootstrap log likelihood test. In terms of the association between pain trajectories and well-being, we'll do a longitudinal latent class causal analysis, and we'll adjust for the baseline physical and psychological well-being. We'll count for baseline confounders, and we'll use a change in estimate approach to build our model. We'll compare models using the AIC and DIC. Additional analyses include assessing for potential misclassification by comparing scores between the Phases Pain Scale revised version and the NRS. This will be done using visual inspection of scatter plots, correlation coefficients, and then we can conduct a sensitivity analysis and rerun our trajectories and our regression model if we find that there is variation between these scores. We'll look at the proportion of commonly used interventions, so these are reported both at baseline and the final follow-up, and we'll compare these interventions across the trajectories. We'll describe changes in pain location over time, and this will be done using proportions of individuals who have increased level of pain over time, decreased, and we can also look at percentage of body pain that's been reported and changed over time with our body map. So for our sample size, we did estimate a sample size of 150 for the pain trajectories, and this was based on Monte Carlo simulations with power of 0.8 and an alpha of 0.05. We did this using different simulations which involved different numbers of trajectories and different distributions across the trajectories. And we found that the sample of 150 was adequate to identify and distinguish between the pain trajectories. For our regression model, we did not calculate a sample size estimate, or we didn't provide one. We're using Harold's convention of between 10 to 20 subjects per variable, and we're on the conservative side of 10 for our regression model. In terms of feasibility, we feel this study is actually quite feasible. Currently, there is an approximate combined caseload of children with cerebral palsy and this age range of 650 children and youth at both sites. We're using a short collection period, so a period of 5 weeks. We have specifically chosen measures that are brief and child-friendly and are geared towards this age range. And there has been prior successful research at both sites, but specifically at Holland Bloorview, where they've collected data on participants over a 2-year period. They were able to recruit 252 participants and had a very high participation rate. And this was just collecting participants using specialty clinics and not the additional recruitment techniques that we're planning on using. We do have good clinician buy-in for this study. Clinicians recognize that pain is important to measure, and there's a lack of this being done. I recently just did a presentation at Grandview for all the physiotherapists there, and it was specifically noted by one of the physiotherapists that she never asks her clients about their pain level and the impact that that has. So they see the need for this, and it's a good opportunity for them to change their way of thinking in terms of approaching their patients. We'll also be getting information from our pilot study in terms of, if there are any barriers to success, perhaps looking at different approaches to recruitment and so forth. So I think that will provide valuable information in terms of our cohort study. Ideally, there will be no changes, and the methodology will stay the same, but we're open to suggestions and if we need to make some modifications. So as with any study, there are some limitations. We recognize that there is possibility for selection bias. So certainly with clinicians, there is the possibility of an overestimate in our effect or in the association between pain and well-being, because we may have clinicians who specifically target to hand out flyers to patients who they feel have higher pain levels or lower well-being. So in order to kind of combat this, we're asking that clinicians hand out flyers to all patients on their caseload who simply have CP and are within the age range. And then it's my job to actually apply the rest of the screening criteria when I meet them in person or I talk to them during the initial phone conversation. We recently found out that we'll be able to compare the group that we're recruiting to the Connect2 research database using age, GMFCS level, and sex. So we'll be able to do a bit of a comparison there to see if there's a difference in participants versus those who are on the client base at Holland Bloorview. And we're also trying to mitigate some of the selection bias using multiple forms of recruitment. So with flyers, electronic posting, the database, and recruitment through the specialty clinics. We recognize that there's an issue of possible measurement bias. So past research has shown that recall of pain over a previous week is actually somewhat higher than average momentary pain reporting. So there is a potential that this could overestimate our association between the pain and well-being. So that's something that we need to consider. And then also there's the issue of parents and guardians who may complete the questionnaires for participants, and specifically at the follow-up periods 1 to 4, where the children are doing these at home. Our best way to combat this is really by advising the parents how important it is to have the children complete the questionnaires versus them, and have them understand that.
I have a question from the online. Are you taking questions now or at the end?
Can we wait until after I'm done? Okay, thank you. So finally, I would like to thank my PhD committee, Dr. Pierre Cote, Dr. Failings, Dr. McKeever, and Dr. Hawk-Johnson for all the support and guidance they provided me so far in the PhD and with the development of this project. Without them, I can say quite honestly, I'm sure I wouldn't have received the funding that I've had to date. I've been very fortunate in receiving salary support for my PhD through CIHR, Kids Brain Health Network, and Brain Canada, and then more recently, an operating grant through the Norman Saunders Complex Care Initiative at FCCS, and then also funding from Holland Review under Dr. Failings, and then support from Dr. Cote's Canada Research Chair in Disability Prevention and Rehabilitation. Thank you. Can you fix the water before we start questions, if you don't mind? Okay. Should we start with Dr. Cohen first? Yeah.
Sure. So thank you, Heather, for a very clear-cut presentation. As a clinician, I can validate that this is an important topic in this population. I'm just thinking out loud a little bit about the conceptual framework of what you're trying to study here.
Sure.
So I take it the correlation between pain and quality of life is not a novel topic.
It's not novel, but there are
generically in human beings.
Yeah.
People who have pain tend to have worse quality of life. Matter of fact, I think pain tends to be on most quality of life instruments, right?
Yes, in several of them.
This is not as well studied in this specific population.
That's right.
What I'm trying to understand, you use the word confounders a lot in terms of what I would call covariates in the models that you're developing. But some of these, I'm not sure exactly confounders, they're more mediators of the exposure, pain, and the outcome, quality of life. And I was just wondering why you decided to call them confounders and what that means analytically in terms of how you're going to think through your data.
Yeah, I've spent actually quite a lot of time on this and back and forth with the committee talking about this. And, you know, conceptually we thought, or I take responsibility for this, I saw them as confounders in terms of them being associated with both pain and well-being. But I agree there is possibility certainly with some of the items we've listed, like pain mitigation, that might be an effect modifier. So, you know, this has implications in terms of the power for our study. So we have 150 participants.
Right.
And if we're going to look at doing some analysis in terms of interaction effects, then we need to stratify our sample. So those who take pain medication or don't, or let's say SPEC. So our estimates will not be as precise if we're underpowered by stratifying.
So before we get into that, I think the second part of the definition of confounder, if I remember correctly, is associated with both exposure and outcome.
That's right.
It isn't on the causal pathway.
Yeah.
So one thing that may be helpful in thinking analytically is actually what is the causal pathway between pain and poor quality of life. And then that might help you make some decisions analytically about what to do. Because you throw all these things into the model, why?
Yeah.
Right?
And, you know, I will say that that's one reason why we're using the change in estimate approach, because I don't want to throw everything in the model. Right. We need to be selective in terms, we're going to use that. And then also clinical sensibility. So what are some of the key variables that we know we want included, like sex and GMFCS level and age? I think these are all important factors that influence both pain and well-being in this population based on, you know, some of the other longitudinal studies that have been done. But I absolutely agree with you. I think this is, it's been a bit of a tough conceptual idea around this. Right. And trying to sort some of this out. When I think of pain medication, I think, okay, well, you know, this is going to influence their pain reporting will be lower, but it can also affect their well-being. So they may have better well-being overall because they have lower pain, which then that's in the causal pathway. But yeah, it's I'll have to think about this further, but I appreciate the comments, and any suggestions you have, feel free to type with us afterwards.
And then there was what I call a hanging chad in your presentation.
Okay.
So you spoke about healthcare utilization as part of your thesis, and it didn't fit into to the analytic plan. So I'm just interested why you decided to include that as part of your thesis.
It's really more of an exploratory question around basically the complexity with these children and the amount of healthcare services that they utilize over time. So we'll be measuring at baseline and follow-up, and then we'll look at change in healthcare utilization or amount of healthcare utilization over that period of time.
So I would only suggest maybe to rationalize why, because it kind of just stuck out as, again, to use the term, not as cohesive with the rest of the thesis, which is otherwise very well presented. Last question. So in the first step of your thesis, you're going to do some modeling to understand these trajectories.
That's right.
You hypothesize these fairly sensible trajectories that you would expect to see.
Yeah.
What happens if your data don't align with those? And how would that influence the second step of your thesis?
Yeah. So with the type of analysis that I am proposing, so we may not end up with 5 trajectories, and we'll test anywhere from 3 to 6 trajectories, but we may not end up with any of them. They may just all plot along increasing pain, let's say.
Right.
So I can't specifically say what type of analysis I'll end up doing. It'll depend on the distribution of the variables, the outcome in the variables. So there'll be some form of regression, whether it's multivariate, logistic, or linear, depending on what the distribution of the variables is. But yeah, it'll be interesting to see, and I'm actually kind of excited to see what these trajectories are. But I agree, I think from a clinical sensibility standpoint, I think we're fairly safe in saying that we are going to see a number of trajectories come out. So, and it may be that we have individuals who are high stable or low stable pain levels, or some variation that way versus the 5 that we've laid out.
Okay, thank you.
Can I ask a question online?
Sure.
Yeah. Dr. Wendy Unger is asking, why not include measure of disease-specific quality of life, such as CP, QOL? Quality of life measures, such as CP, QOL.
So I am using the outcome of the Kidscreen quality, well, it's a quality of life or well-being measure. And I specifically chose that because it has been tested in large populations with CP, specifically in Europe, it was tested there. And then in smaller groupings for reliability and retest. But there's been a couple of cohort studies, actually. One that was done over 5 years with this measure, and another one in Spain that was taken over 3 years. And this has very good psychometric properties, so that was why we chose this one. But I'll certainly look at that measure and compare it.
Yeah, I have some great presentation. I'm an adult neurologist, so I'm not familiar with a lot of the kids things, but in the adult world, every time we try to correlate pain with quality of life, there's other factors, and we talk about pain catastrophizing and pain impact. So I don't know if there are any tools available for kids. I know we've used a promise that pain interference quite a bit, and I'm pretty sure that we may have a pediatric one, but that's something to consider because some at least in the adult world, I suspect the older kids or teenagers closer to adulthood, some people have high degree of pain, but they have pretty good quality of life. They manage pretty well. The pain doesn't interfere, so I think that's an important thing to think about. And in terms of the outcomes, I just recently had to review the Kidscreen for another population of patients. And I know we have cohorts in CP, but I think it was developed originally for healthy kids. So when you look at the items, the physical functioning, the domain is quite small and has very little on pain. So that's when maybe a disease-specific you don't want to miss important correlations, because even though it's psychometrically sound, the actual content may not be that good for this specific disease. And the same developers of Kids Screen has something called the Safe Kit. So it's also very well developed, but it's more focused to kids with disabilities. So I would consider looking into those just to make sure you're not not picking up stuff just because the outcome may not be that good for your population.
Okay. All right. Thank you. Yes, Dr. Borka.
Great presentation. I wonder if you could talk a little bit about what you would do missing data. Like, what if you only had time one? Have you thought about that?
Mm-hmm. So with the latent class growth mixed modeling, the nice thing about this analysis, I should say, is that you can use certain techniques to account for missing data. So, and then we can also do sensitivity analysis to say if we only have pain reports for 2 out of 4 of the outcomes, what difference does that make in terms of our trajectories? But there are techniques for missing data with that, and then we'll use imputation for the regression for any missing data there.
Right. And I wondered, you're measuring the well-being at the very last visit. Would there be benefits to measuring it at every time point as well?
Yeah, this was something that I thought about quite a bit at sort of the conception of the study. So how soon does well-being change when a person's reporting pain? So what's kind of the lag time of this? And there were a couple of considerations, and there's nothing in the literature to provide any answers with this. So we conceptually felt we were better to track pain over time and measure a change in well-being from baseline to final follow-up. The other issue that comes in is burden to these children. So we really worked hard to pick measures that were easy for them to answer. We tried to minimize the type of questions that were being answered. So using the FACES pain scale or the NRS, and the Kids Screen measure has been used in children with cerebral palsy with very good success, and relatively easily administered. They actually used the Kids Screen 52 in one of the larger longitudinal studies. And we chose to use the Kids Screen 27 because it captures the domains that we're interested in, but still maintains good psychometric properties. So, yeah. Thank you. Thanks, Dr. Lelou.
Thank you. That was a great presentation. I just like a couple of questions. Your recruitment methods seem quite robust, and you're using kind of different methods to try and get the study. I was wondering if you're going to be capturing data on like yield of patient or yield of participants for each method. So your Connect to Research database and the posters, and if you have your substantial sort of collection.
Yeah, I will actually be tracking for recruitment, which method, the percentage for each method. So how many we get enrolled through Connect to Research and how many are from the specialty clinics. Because I think this, and we'll actually be doing that in the pilot study as well, it'll help guide us and target us towards, especially if we find that we have slower recruitment, where we can maximize recruitment down the road within the study, because this isn't a study that's going to take 3 months. It's a bit of a long haul study, so we want to make sure that we're tracking where our recruitment's coming from and being on top of that.
For sure, and it'll be helpful for future research.
Absolutely.
Great. And then one other question. You mentioned the potential for discordance between the recalled pain intensity, which is collected, like recalled for the past week, versus like a daily pain rating. So I was wondering if you considered using like a daily diary, collect the data because you're looking at trajectories versus like the weekly.
Yeah, we did look at that. That was one of kind of the original conceptions of the study. So are we going to do this over 2 weeks and collect data daily? Are we going to do it for 4 weeks and collect data daily? And before I went to the Youth Advisory Committee, we had landed on once a week for 4 weeks. And then I had the opportunity to discuss with them in terms of, what's most feasible for them in terms of school and recreational activities, and really are they going to respond to questions? So we had quite a bit of, and now these are teenagers, so they may not be quite on it as young kids with parents who are helping them answer emails, but we had quite a bit of feedback in terms of, I need extra reminders for completing these responses. So are you going to give me a sheet that details out the schedule, so a hard copy, plus will you send email reminders the day before? So we've actually built that into the protocol, where they'll be given a physical copy with daily reminders our weekly reminders for the day before. They'll get a call the day before to remind them to complete their questionnaire. And then if they miss the questionnaire, they'll get a call to complete the questionnaire, or they can do it on phone at that moment. But they did say that they felt that they would have trouble completing a daily diary. Now, if we could provide technology to them, we don't have the funding for that, but that would be something novel for them where they can complete it on a handheld device if they don't have one. I think that would help improve response that way, but that's just not in the cards for this study. So, thank you. Yes, Dr. Kron.
I'm sorry I missed the first little part of your presentation, so maybe the answer to this is obvious, but just picking up on one of your comments, I mean, pain is part of most conceptualizations of health-related quality of life, and so the outcome instrument that you choose, I mean, the structure of that is going to condition your outcomes to a very large extent in the way that it represents pain as being part of quality of life. So some instruments feature this prominently, it's heavily weighted. For others, it's less prominent. Like, how are you going to deal with the fact that you're dealing with a particular way in which health-related quality of life is conceptualized for your primary outcome instrument? Do you know what I mean? I mean, maybe the option is to choose a couple of other instruments in addition where health-related quality of life is conceptualized in a different way, or where pain has a lesser degree of prominence. But I get the issue about response burden in this population. I totally get that. But if you're trying to understand how pain and quality of life are related, are you not at the mercy of the people who sort of created an instrument with a particular a priori idea how those things are related?
Yeah, so I think I should talk a little bit about the instrument development for this. So I'm focusing on two specific domains within this instrument, so physical well-being and psychological well-being. So within those two domains, there are 5 questions related to kind of the physical health-related quality of life, and then there's 7 for psychological and emotional well-being. So it was quite a process when they actually developed this questionnaire. They did a literature review. They then went through, and it started with the Kidscreen 52, and then it was reduced. They did item selection for the Kidscreen 27, but then they actually did a 3-round Delphi survey with children, with both healthy children. So it was, you're right, it was tested in a healthy population, but also children with chronic diseases, a smaller group within that population. And then they did focus groups with specifically over 300 children, both with health conditions and a healthy population, in terms of making sure that they're collecting information about what represents health-related quality of life to them. So a variety of different domains, so it could be social and whatnot. I certainly understand that I need to think potentially a little bit further about making sure that I'm capturing the physical well-being outcomes. I'm not.
It doesn't matter how well it's done. There are always 6 ways to do it.
Yeah.
Right? I mean, so even if it's the most perfect process, you're ending up with a product that's the result of a series of choices along the way. Anyway.
Yeah. So would you recommend adding another health-related quality of life measure?
Questions along that line. I mean,
Yeah.
That was Wendy's question, right? I mean, she asked about bringing in a disease-specific quality of life measure, or if you're targeting well-being, maybe something that is like more well-being-ish as opposed to health-related quality of life, like a simple linear analog measure of subjective well-being, or something like that.
All right, thank you. That's very constructive feedback.
But those items you just mentioned, they don't ask specifically about pain then? The items you were just mentioning in the second and the...
No, so I can, I don't know if I provided that for you. I can actually read you the 5 items. So it's, in general, how would you say your health is? Have you felt fit well? Have you been physically active? Have you able to run or move? The question we've been modified. And have you felt full of energy? So it's not specific, there's not a specific question asking about that. I think conceptually that would be difficult for children, especially on the younger scale, to be able to conceptualize well-being. So they've structured it this way with questions, but I'm happy to definitely look at other measures to see the kind of overlap and and see if we need to consider this.
So, I understand correctly, it's 2 steps. First, you're finding trajectories and classifying people according to the trajectory group they fall into, and then looking at the relationship between trajectories and your quality of life outcome.
That's right.
And your trajectories are growth mixture models, so you have a random effect between people around the average trajectory for the group. Is that correct?
Yes. So they'll be considered subpopulations within there and distinct groups within.
Right. So you've got 5 average trajectories, and then within each trajectory group, you're allowing people to randomly vary around the average.
Yeah.
Is that right? So someone could be, say you've got these stable groups. Some could be stable high or stable low.
Yeah.
Okay.
So that might end up being, depending on the number, 2 separate trajectories that we end up having to report.
But if there's a lot of between person heterogeneity in the sort of trends, it could be that you've got a stable group, but some people are stable at high pain levels, and some are stable at low pain levels, or medium pain levels.
Yeah.
Okay.
Yeah.
So I have 2 questions. One, you have a fluctuating group.
Yeah.
So are you parameterizing these growth curves using polynomials? Is that the plan? You don't know.
I'm going to defer to Dr. Johnson.
There's 4 points, not a lot of room.
Yeah,
for
there's not. Yeah.
fluctuating. So that's probably going to be difficult.
Yeah.
And then I guess my question was, see, this quality of life measure is asking about quality of life. Is there a time frame that it asks about?
It's in the past week.
Past week.
Yeah.
Okay. It's possible that, yes, well, the past week people quality of life may be influenced by their current pain at the end of the 4 weeks rather than how they got there.
Yeah.
Right. And so even within a trajectory group, people could be at different levels of pain. It could be stable, and stable high or stable medium, and you're saying they're in the same group, even though they're at different levels of pain. So that, in a way, undermines the association between pain and quality of life if people actually have different levels of pain. You're saying they're in the same group.
Okay. Will we chat about this further? Okay.
I mean, the data may reveal that, in fact, trajectories vary by intercept. So they may be, one trajectory may be stable high, one may be stable low. The data will hopefully help.
But maybe it doesn't matter how you got there. It just matters where you are at the end. If you're asking about pain the last week, but I'm not sure if someone asked me about, I don't remember how much pain I had 3 weeks ago, but I know how much pain I have now. So that may be, my quality of life may be assessed based on how I'm feeling now rather than, oh, I'm getting better, I'm still in a lot of pain. So, or I've gotten worse, but I'm not much pain.
Go ahead.
Anyway, sorry.
So George, would you suggest that the pain measurement stops at 5 weeks?
Well, I don't know. I'm just thinking a potential problem with
life is measured later to avoid.
But we're doing that. So our pain measure stops at week 4, and then our week 5 is the
No, I'm just thinking, you may not find the relationship you hope, but potentially it could be because, it doesn't really matter how you got to where you are, it's just where you are at the end. Right. So, it may be that people think their quality of life is good because they're in less pain than they used to be. But they're still in a lot of pain. I don't see why someone would think, great, I'm in a lot of pain, but I'm better than I was. So you may not, so I'm just thinking of reasons you may not, hypotheses may not pan out the way you're supposing, but you could still look at the final association. And also, I think someone said, why not measure quality of life every week? Then you could look to see if those things kind of move in parallel.
Yeah, we actually had thought about that earlier, but it
too much of a burden.
It's a lot for kids, especially if we're not doing this. If we're not doing in-person interviews, so they're then expected to answer these questions. We'll send them out, and so it'll take about 5 minutes to do the pain measures once a week. But then once we add in the kids screen with the 27 items, just that questionnaire alone is about 10 to 15 minutes. So to ask them to do that weekly for 4 weeks, it's not unheard of. It can certainly be done, but we're just trying to keep it to a minimum.
Well, just following from one of Murray's ideas, the visual analog scale would take almost no time to complete each week. If you want to tack on an extra measure of quality of life, which isn't much of a burden, so if the quality of life is fluctuating in tandem with pain, you might miss that by looking at quality of life versus the trajectory of pain.
Okay. I'll look and see if there
maybe add it at the middle. Add one more at the middle.
Yeah.
Add the kids screen at the
middle. Sort of times 3, is it?
Yeah, there's no real middle, but I could do it at time 3, potentially. Okay, that's definitely something to consider. I'm just going to make some notes here. Thank you. This has been very helpful in terms of feedback. there another?
No questions, but actually Dr. Wendy Unger was mentioning that she's willing to send you more information about the measure that she was talking about.
I would really appreciate that.
So if you could give me your email, I can share that.
I'll be happy to do that. Yeah, and if anybody has any information that they'd like to pass on or share with me, I'm more than happy to share my email and have follow-up discussions. So, yeah.
Can you oh, thanks very much, by the way. Can you go back to the, I don't know if it's a slide, but just your thoughts around the sort of follow-on question after you find what you find, and assuming that there's going to be some relationship between trajectories and sort of well-being. This isn't meant to be so blunt, but the so what question, right? So you find that there's a relationship, and presumably people are thinking, thinking, there's probably a relationship, and you describe that. So how will this knowledge then be used by you in the future, or as you indicated in your proposal, potentially by families?
Yeah, and I think this is a really important point to address. So we've actually applied for a CIHR project grant where we outlined a whole KT kind of component, and part of this goes to including families or parents and children, as well as clinicians, in quarterly seminars in terms of what the information we're collecting is for, information that they can provide, and ultimately what we're going to do with it. So, I mean, if you think about this, just in terms of identifying different pain trajectories, so how is this going to influence clinicians' practice? So if they see kids who are constantly reporting higher levels of pain, are they going to think about referring them to pediatricians or specialists in terms of managing pain, or looking at different types of interventions if they're not having frequent interventions? So do they need to be put on different medication or started on different medication? Also in terms of well-being, so it's not something that I think clinicians are necessarily attuned to, but certainly as children, we know the literature shows that as children move into their teen years, their well-being tends to decrease. So it's something that needs to be kept at the forefront when clinicians, and also for families, when they have these kids, to keep in mind well-being and what can be done for them. So there are certain coping strategies that can be provided. So especially kids who have higher pain levels, what are we doing to ensure that they're not getting into trouble with lower well-being and running into other consequences? So potentially mental health issues or depression related to feeling low or down. So it's really, providing that kind of spur for clinicians and patients and families in what to do if you have high pain and if you have low well-being. And I think it was really telling when I did the lunch and learn with the physiotherapists at Grandview, and I had 7 physiotherapists in the room, and all of them nodded their heads when the one physiotherapist said she never asks her clients about pain. It's always about function. So, what are they doing this week? How have they been? Did they do their exercise? But it's not, did they say they were sore, or is anything hurting? Or she said she has never in her 15 years of practice specifically asked about pain. And that was a bit shocking to me because with my training, that's kind of one of the first questions that you ask is, what's your pain level today? But it's not at the forefront for kind of rehab care with these kids, and understandably so, that it's just the training that they've received. So I think it's important to do this study so that we can change kind of the thinking, certainly with some of the key clinicians who see these kids fairly regularly. Dr. Lalu?
Sure. So to measure pain intensity, you'll be administered both the basis in revised and in numerical rating scale.
Yeah.
And then you talked a little bit about how you'll be comparing the scores to look at potential for misclassification.
Yeah.
So if there's disagreement between the two scores in terms of like which trajectory it would fit into, how would you sort of resolve that?
So what we'll be doing is looking at the differences in the scores, because they both have numerical components. And if there's a difference, so we're going to use the basis pain scale revised for our primary analysis. And if there's a difference, then we'll do a sensitivity analysis and rerun basically the growth model using the scores from the numeric rating scale, and then rerun the analysis for the association to see if there are any differences. One of the reasons why we chose the FACES pain scale over the numeric rating scale, so there's a good amount of evidence for using both of those scales in the acute pain population, but there's weak evidence towards chronic pain use. And we chose the FACES pain scale specifically over the numeric rating scale because of the issue with potential problems with numeracy, especially in the younger group. But one of the feedback items that we got from the Youth Advisory Committee was that from these teens, they're used to being asked to measure pain using the NRS. So that's why we've actually included both measures, because originally when we first conceptualized this, we were only going to use the FACES pain scale revised version. So we think it's important so that we're kind of meeting the needs of younger kids as well as older kids, as well as potentially some who have intellectual impairments and have issues with numeracy.
I just one suggestion. So when administering the FACES pain scale,
Mm-hmm.
I had a look in your appendix. You had kind of the instructions for what you would say to the patient.
Yeah.
Choose the face that reflects how much they hurt.
Yeah.
Sometimes it's helpful to say, choose the face that reflects like how you feel inside, because sometimes there's some kind of confusion that if the face looks sad and they feel sad, they would pick that. So sort of a confusion between pain versus like emotion.
Mm-hmm. Okay. We tried to stick with the wording that was suggested with that, except for interchanging the word pain and hurt, because we know with kids we're able to do that. But I'll look at that. Is there literature to go along
There is,
with that? Okay, that would be great. Thank you so much.
Yes, we have one more question from Dr. Conferred here.
Okay.
And that is, will it be possible to blind responders to their previous week's responses?
So they'll be answering using a link to REDCap. So they basically click on the link, they complete their score, and then it gets automatically entered into our system. We haven't blinded, so the immediate response, they're able to go back and see what the FACES pain scale mark is to the NRS. They can go back and forth on the questionnaires, but we haven't looked at actually disabling the previous link in REDCap. That's a good thought. We can certainly do that. So, yeah.